Hello and welcome back to our didactic series on emergency department crowding. This is Module 2, Causes of Crowding. I'm Brian Franklin. I have the privilege of working with Eric Gralnick on these modules. This is Module 2 in a three-part series on ED crowding. In Module 1, we defined ED crowding and examined its impact. In this module, we'll discuss the causes of ED crowding. This module is organized into an introduction of the classic input, throughput, output conceptual model of ED crowding. We'll then take a look at each of those factors individually. Finally, we'll discuss the hospital financial incentives that may contribute to ED crowding. One of the most widely cited frameworks for conceptualizing ED crowding is this input, throughput, output model. This model organizes ED patient flow into three distinct phases with problems and corresponding countermeasures for each. Now let's take a look at each factor in more depth. We'll start with input factors. Input factors are those that drive patient presentations to the ED, and we can broadly categorize ED patient visits as those that truly require the ED and those that may not. Visits that truly require ED care are those for emergent conditions and those involving symptoms that may potentially represent emergencies requiring resources or timeliness of workup available only in the ED. Then, of course, there's a large category of visits that ideally would be addressed at alternate sites of care. These are visits for conditions that could be addressed at primary care, urgent care, or retail clinics. This also includes visits for conditions that could have been prevented entirely with appropriate primary care. Patients present to the ED with these conditions because they don't have access or what they perceive to be appropriately timely access to primary care or these other sites of care. So it's difficult to say how many ED visits are unnecessary, in part because there's no consensus in research or policymaking as to what constitutes an unnecessary ED visit, or even the terminology used to describe these visits. Depending where you look and how you define unnecessary ED visits, there's extreme variability in what proportion of ED visits are reported to be unnecessary. And of course, it's also worth noting that the specialty of emergency medicine prides itself on being the safety net for society, and it's a privilege to care for patients who can't get help anywhere else. But the point stands, as everyone knows, particularly for the sake of patients, there are a lot of ED visits that probably shouldn't require the ED. Next, let's discuss throughput factors. Throughput factors are those that relate to ED care processes from the time a patient arrives at the ED until their disposition is determined. And you can see there are many processes involved in a patient's visit, which to various degrees are under the control of the ED. Some of these processes occur in parallel, for example, when a provider is placed at triage. Four major points for intervention are time from patient arrival to provider evaluation, time from provider evaluation to order placement, time from order placement to order result, and time from consult request to consult fulfillment. If one of these time periods is consistently excessive, you can start to imagine the types of interventions that could be deployed. For example, provider and triage programs are designed to reduce the time from arrival to provider evaluation and order placement, and we'll discuss that program further in Module 3. Once you determine a patient's disposition and try to send them home, that's when you are talking about output factors. Disposition is often either admission to the hospital or home or wherever the patient came from. In the case of admitting a patient, if there aren't enough inpatient beds, patients who have been admitted to the hospital get stuck in the emergency department, and that's boarding. Boarding, again, occurs because there aren't enough available beds in the inpatient environment, and that could be for many reasons. It could be because there aren't enough nurses or other caregivers to staff the beds upstairs, or because there just aren't enough beds. Then when you start to ask yourself why there aren't enough beds upstairs when you need them, maybe you'll find that there are inefficient care processes that prolong inpatient length of stay, or maybe there are challenges securing subacute rehab beds, so patients who could be discharged get stuck taking up valuable hospital beds, or some combination of all of those factors. In the case of patients who could go home, sometimes ED providers spend lots of time making sure those patients will have adequate outpatient follow-up, which can be distracting from caring for other patients in the ED. And if they're unsuccessful in arranging follow-up, then those patients are more likely to be admitted, which of course exacerbates the problems we just discussed about lack of inpatient bed capacity. This is just a reminder of the definition of boarding, which occurs when patients are held in the emergency department after being admitted, and boarding leads to crowding. Here's a study from back in 2003 that found every 10 percentage point increase in inpatient hospital occupancy is associated with an 18-minute increase in ED length of stay for admitted patients. And that may not seem like much, but if you have 30 patients, for example, you've admitted in a day, that's 540 minutes or 9 hours of patient care time in ED space used per day. It's also worth noting that as hospital occupancy exceeds around 85%, multiple studies and models have found that ED length of stay at that point begins to increase exponentially. Now let's discuss some of the hospital financial incentives that are thought to be root causes of ED crowding. Here's a commentary from the fall of 2021 by a number of chairs of emergency medicine. They assert that while the input, throughput, output model that we just discussed is helpful, a lot of the discussion around ED crowding misses what they consider to be the true cause of access block, which is hospital financial incentives. To discuss hospital financial incentives at a high level, we can think about the two main sources of admissions to the hospital: admissions from the ED and admissions for elective surgical procedures. On average, ED admissions are less likely to require highly compensated procedural care, and patients from the ED are less likely to have good insurance. On the other hand, admissions for elective surgical procedures garner higher payments from payers, and patients who come for those procedures are more likely to have good insurance, particularly because their insurance status is often pre-screened. So the argument is that hospitals would rather reserve inpatient beds for patients undergoing elective surgeries, and then whatever inpatient bed capacity is left can be used for ED patients. And optimizing for elective admissions at the expense of ED crowding may be thought as the economically rational thing for hospitals to do under current payment structures. That doesn't necessarily make the practice appropriate, but it at least makes it predictable economically. So that's the argument. It's worth noting two sort of counter arguments. First, allowing ED crowding to occur is not costless to hospitals. So when the ED becomes overcrowded, some patients will get tired of waiting and leave without being seen. That, of course, can be unsafe for them, and also their money will go with them. Second, this is just a general discussion. The economic calculus is going to vary at each hospital based on its case mix, so what kind of patients get admitted through the ED and what intensity of care and reimbursement they command, along with the hospital's payer mix. So are these mostly patients with commercial insurance, or mostly, for example, Medicaid patients with lower hospital reimbursement? So in summary, today we discussed 4 drivers of ED crowding. Input factors. And when we talk about input factors, we talked about addressing ED visits for conditions that could be addressed at alternative sites of care, or for conditions that could be prevented altogether through better primary care. We discussed throughput factors, and in particular, the idea of reducing time from arrival to provider evaluation, from provider evaluation to order placement, from order placement to order resulting, and from consult request to consult fulfillment. In terms of output factors, we discussed access block, meaning no beds are available upstairs when you decide to admit a patient, which results in inpatients boarding in the ED. Finally, we discussed financial factors and the idea that under current payment structures, on average, hospitals have an incentive to prioritize elective surgical admissions for inpatient bed capacity at the expense of having too few beds available for ED admissions, causing admissions to back up as boarders in the ED. And this slide is to reiterate the point that the root causes of crowding, so whether those are input, throughput, output, or economic factors, those vary by hospital. So if you're trying to solve ED crowding in your ED, step 1 is to identify and quantify the root causes of crowding in your ED before identifying solutions. We'll discuss this further in Module 3. And on that note, check out Module 3 for a discussion of potential solutions and specifically countermeasures to each of the drivers of ED crowding we just discussed. Hope to see you there.